healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Welcome, everyone, to another episode. I'm your host for today, Viveka Jagadisan, filling in for Stuart Newson. And today we have a special episode lineup that I'm really excited about. We're going to dive deep into the top 5 denial reasons in cardiology practices, compare our findings here at Infinix with what we see across the industry, and most importantly, discuss some proven strategies to prevent those denials. So I'm excited to introduce today's guest, Bo Bowman, who brings a wealth of knowledge and experience in revenue cycle management. Bo has been a key voice in the healthcare space, and I'm looking forward to hearing his insights on how cardiology practices can mitigate the denial risks they face. Welcome, Bo. It's great to have you here.
Hi, Viveka. Thank you.
So, Bo, let's get into it. Today, we're focusing on cardiology claim denials, something that impacts practices across the board. To kick things off, first big question, what are the top 5 reasons for claim denials that you're seeing in our cardiology practices today?
Sure. Thank you. Thank you for the opportunity and great topic for sure. There's a lot of focus in the cardiology world today on the bottom line. Whether your revenue is coming from a shared relationship that you may be in and an ownership, or you're an independent practice, everybody's looking at the bottom line. So the key portion of that is to make sure you have a tight revenue cycle. And the big interrupter that we're seeing across the board right now is the denial and denial management function. And so we really want to stress today that, hey, whether you're running a small 1 or 2 provider or a 70 to 100 provider practice, spending some time looking at your denials on a weekly basis and taking the action plans that we're going to talk about today is extremely important, and it will impact your bottom line, and you'll see improvement. And Infinix is happy to come along and help you there. So basically the kind of the denial landscape today, number one that we unfortunately see most often is around authorizations, prior authorizations, and really the work that goes into getting that authorization when the either diagnostic or procedure that the doctor has ordered needs to take place. Some of these often, given that we're dealing with matters of the heart here, have to take place in a rapid fashion. So, we may only have 1 or 2 or maybe 3 days if we're lucky to get the authorization. And there's a couple of pieces tied in there. For instance, we also have to have a referral in place for most of the major commercial HMO and PPO insurances. So making sure you have the referral, making sure you have the correct order, making sure the order matches the order for the diagnostic or procedure matches the diagnosis of the patient, having all of that information up front, then to go spend the anywhere from 20 minutes to 1 hour it can take using either the portal for that insurance or potentially phone call. It's a strenuous process with a lot of follow-up. So we do see quite a bit of denials. A good denial rate in a cardiology practice these days is running anywhere between 8 and 10%. So let's just say if you have 100 denials in a month, we've seen upwards of 50% of those denials be due to not having the authorization in place or having it only partially authorized, meaning some of the codes, but not all of the codes. So again, significant issue on prior authorization. What's the remedy there? Automation. And, what can you do to make sure you have all of your documentation in place? And we'll dive into that as we get further into the discussion today. Next one is around coding. We do see quite a bit of denials due to coding. Oftentimes, this is more about not necessarily that the physician didn't put the proper codes in, or in fact have the medical record or the chart completed, but that is matching up the right codes for the right diagnostic or the right codes for the right procedure, and then making sure that you are in line with your certified professional coder or your coding vendor. You have all the documentation that supports the codes. So, some kind of common things that we see in the coding world right now, for instance, on a nuclear scan that a patient may have, oftentimes we don't see the invoice included for the rubidium. That's a necessary function to make sure you're doing the diagnostic the correct way. So we'll see a denial there or a short paid claim. Very oftentimes we see missing modifiers, typically on more complex procedures. A big one is the LCDs, local coverage determinants, are following really what each payer plan says you must have for the proper codes to get the authorization. And so that's a non-covered service denial. We get that. We see that a lot more often than I think practices would like to deal with. And then lastly, again, the diagnosis does not match the procedure ordered. So all of those kind of fall under the coding denial world. We could probably go on and have a whole session just on those, but that's a big one. Remedy there, coding audits, regular, quarterly, disciplined coding audits where you've either outsourced to a coding vendor and they have a separate quality check or a separate quality audit that's on top of the production coder that's assisting the physician. We have that in Infinix. We have quality coding auditors that review what our coders are doing. Then we sit down with the physician 2 or 3 times a year, depending on their level of claims volume. And we do an audit of, say, 20 charts. And then we walk through, hey, where were you in relation to the Medicare norms, and really grade those out. Very helpful tool. We've seen a lot of coding improvement from various practices through that process. The next one is denial rate is around medical necessity and medical record documentation. So this is a tough one because automation can't necessarily fix this. We do have processes in place where we can pull the necessary record and the necessary documentation based on a patient's diagnosis, but you're still, looking at a manual process here to ensure you have the documentation that supports the medical necessity to have the procedure or the diagnostic, and that you've pulled all the necessary records. Most of the time, those records are in the EMR. So, with the right training and the right protocol, shouldn't be a difficult thing to have them all placed and attached to the claim prior to transmission. But sometimes we've got to go get records from the hospital. Sometimes we have to retrieve them from a historical visit that may be in another system. And so you start to run into kind of this domino effect of manual processes that you have to go through to make sure you have the correct documentation when you submit for the authorization and submit for the claim. Again, very challenging process. So what do we do about that? We like to develop templates. So, for the different, say, 12, 14, 15 type visit types that we see in a cardiology practice in a given day, we like to see the practice create templates for each one of those. So either the tech, the nurse, the admin, assistant people that are trying to help make sure everything's there, the billing team, they're following that template. So again, if it's for a PET diagnostic or if it's for, maybe it's an electrophysiology procedure that's being scheduled, the doctor, the tech, and the nurse should have an agreed to template on all the information that's going to be pulled. So when it gets to the billing team, they're able to successfully submit the claim without the denial. So that's around documentation and medical necessity. Another sort of remedy that we've done quite a bit there is really, again, kind of match up. Hey, for this particular diagnosis, we know we need this history of medical necessity. We know we need this history on prior procedures. And even then, what we're seeing a lot, the insurance company will send it to a peer-to-peer. And so that once again, kind of slows the process down. So, again, using a checklist, using a template, and we've got to the point where we can even load that into the client's EMR. So right when the order is done, again, the tasking team, whether it's the clinical team or the billing team, can follow those checklists, can follow those templates. So when it finally gets time to go forward to make sure we don't get a denial, we've got all of that in order. Last one, but not least, that we run up quite a bit is really the timeliness of how we get this information together. And again, I started off with saying, hey, we're talking about cardiology here. It's not dermatology. It's, you're going to need your diagnostic depending on what really the health of your heart is. And, maybe it's, Thursday and you've got to have the diagnostic Monday. And so we really do run into how quickly we can put all the documentation together. And then potentially we still have to have the diagnostic. We may or may not have everything together in time. So again, having those check sheets and having those, kind of your submission tools is also what I like to call them, will help in the speed of that. Because we do see quite a few denials due to either had the procedure, didn't have the auth in place, and thus we keep trying to retro auth, and then we get up against the pass filing deadline. And so unfortunately we do see, denials that end up yeah, I say getting terminated and the claim gets adjudicated and unpaid, because we spent those 60 days trying to get everything done to make sure we could, appeal it. And at the end of the day, the timing, it just didn't work out. So, there's a real protocol that has to be developed. And, at Infinix, we like to say that we're always working 7 to 10 days out. And that's really just our standard. We love to see 14 days out when we're providing authorizations and ensuring that we're getting everything done, so we don't see that unfortunate denial come up. But those are really kind of the top five. There's more out there that we can kind of hop into as we go through this. And one that I didn't maybe mention that's important too are duplicates. We do see denials quite a bit for claim duplicates. This oftentimes is a good intention, a well-meaning error, meaning that we see that we didn't include everything on the first time, the claim was potentially transmitted. So we do avoid and recreate, we resubmit it, we end up getting a denial from that. So got to have a protocol in place on how you do your void and recreates when you're going back through and reworking your rejections from the clearinghouse.
Hey, wealth of information there, Bo. This might be something that all of us will be re-listening to. A lot of good strategies in there. So, Bo, how does the data that we've gathered here at Infinix compare to what you're seeing across the industry in terms of cardiology denials?
It's a little bit in reverse. So really, if you're, I'm a former finance person and a former budgeteer, and so I always like to have a plan. I always like to have a budget or a forecast that we're trying to hit in any means of our business. And so, the way we manage denials, and specifically in cardiology, shouldn't be any different, right? You should have a course set out for you. So, really, let's just take kind of the perfect practice, if you will, or the model practice, really based on how complex payers are and what they'll approve. Really, kind of what we like to see is that if you're going to have some denial issues, the first reason would really be more around eligibility, right? And that's gets all the way back to your front desk, checking the patient's insurance. Is it caught up? Is it current? Is the patient eligible for this service? If not, do they need an ABN? Do they need another visit to achieve the medical necessity? So that, I say, eligibility is what we almost prefer to see in the denial world, because that gets back to it's in the physician's control. They're autonomous for that patient's care, and we're just trying to make sure that we've covered our basis with the eligibility. A next kind of denial we'd like to see, if they're going to occur, is more like in the area of just need additional info. So everything that we submitted, codes, we got the authorization, everything went through, but they needed one more document. Maybe it was the result of the last cardiac procedure the patient had. Pull that record from the hospital, resubmit it, claim gets paid. Those aren't necessarily uncontrollable, but they really are kind of payer driven, and there's not a lot that practice can always do about that. The next one down, kind of, so eligibility, additional info, coding, right? You're always going to have some challenges with coding depending on who the payer is. And then I mentioned early duplicates, and then last but not least, authorizations. So in a perfect world, you really want to be fighting the insurance company at the eligibility level, and then making sure you're providing the additional info. And then if you need to alter your coding, you can. Unfortunately, out there, what we're kind of seeing in the world when we're using, our platforms to help clients understand, is the reverse. And the reverse is we're seeing authorizations, and we're seeing that, insurance verification and really making sure that you've got all the document in place to go get the authorization. We're seeing that as more of like the lead cause of a lot of denials. So, and then from there, going back and fixing and trying to get a retro or going to fix that authorization to ultimately do denial management, that's where you're kind of opening up Pandora's box of a whole bunch more problems, right? Because we didn't get the auth on the first place. Now we've either done the procedure or we've had to postpone the patient, right? We've had to postpone patient care because we didn't have everything in place. So that's what's kind of we're seeing in the landscape today. Is what we'd like to see is more like, hey, there's a little bit of eligibility concern we have here, and we need to go get documentation to make sure we don't get a denial. But instead, we're seeing the payers being very, very stringent on, do you have everything you need for the authorization? And if you didn't, we're going to deny it, make you start all over again. It can be very frustrating, can be very demoralizing for the, whatever it is, front desk, back desk, billing staff in the clinic.
So the reality is some of these denials are really much more easy to fix from the practice's standpoint, but we really are seeing that it's those prior authorization denials that are, the lion's share of these, it sounds like, and that those really are going to be a lot more work maybe to remediate and perhaps not entirely within that practice's control, unfortunately. So I would like to dive in a little bit more on the coding question, Bo. So given that, you said coding errors are often at the root of these denials, I'm just curious from your perspective, what are the most common kind of coding related mistakes to be aware of that you see folks leading to denials in the cardiology realm?
Sure. At Infinix, we have on our kind of our main RCM team, we have 5 now senior cardiology coding auditors. So that team meets with our physicians on a real regular basis that we support. And so, what comes out of those meetings is what I'm usually, kind of curious about or attending. So bundling and unbundling. So depending on, how many, what was the patient seen for that day? And then, if they did have multiple procedures or if they did have multiple diagnostics, how do we submit that? Do we bundle the codes correctly? Or should they have been done and submitted separately, i.e. unbundled? So within the coding world, our coding experts are very well trained on when it should be bundled, when it not should be, and how to submit that. So that's a big one I'd like to bring up. Another, just if we're going to get into some of the diagnostics that are tough, loop recorders, ILRs, a very important, technology and a great opportunity to really track what's going on with the patient in the cardiology world. Quite difficult to bill for. You've got to have the necessary modifiers in place. You've got to have the necessary medical record documentation to really substantiate the use of ILR. Another one we see a lot of denials on is insertion pacemakers. Again, you need a very specific diagnosis to get a pacemaker insertion and then the associated claim for that work all the way through first time for a clean claim pass. A lot of that has to, again, do with all of the coding and making sure whether the coder is doing it from an abstract perspective or working through, what the doctor has submitted either through the hospital EMR or the practice EMR to make sure you have all that in place. What do we do about that? Again, a template per procedure. I call them cheat sheets or reference sheets. We're happy to help the practice create those. And then we can update those each year based on what CMS has said that they will or will not continue to pay on a given set of codes. But again, can be very, very frustrating for the doctor because you're going about like, well, what should I do first? Should we do a Holter monitor first, see how the patient does with that, and then move on to a different type of, tracker for the heart arrhythmia to see if there's any issues. And, sometimes the payer will come back and say, we're not going to pay on the ILR here because you didn't do the Holter. And so again, some of this, gets down to how each payer sees how the care event should be in line. And it can be very, very frustrating for the physician and then very, very frustrating for the billing team because, again, everybody means well, but we're seeing a denial come on that. And then we've got to go back and do denial management. So I kind of hit on it earlier, not the modifiers. There's at least a dozen modifiers that we see denials for. So doing some coding education, sometimes the modifiers change from year to year, depending on how CMS rolls out the fee schedule. So again, we'll do an annual update with our clients to make sure they're aware if there's a new modifier they need to be using. And then again, one more is that diagnosis doesn't match the service provided. And so, a physician may think, okay, well, we need to do this, this, and this. Before that, the diagnosis has to be either expanded, have the right scope, and the coder needs to pick up on that and make sure that's included in claims transmission. So a lot going on with coding. Again, would highly recommend at least twice a year audit, and whether you're going to, use your internal team or hire a vendor and outsource to do so. Those are all good means, but it's absolutely something to be done. And you'll see your clean claim rate improve. Maybe the clean claim rate you have in your practice is, up in the high 70s or low 80s. Paying attention to this coding piece will really jump you up real quick.
Okay, so Paul, I'm seeing a question from our audience, and they would like to know what a practice can do if they do see that same denial reasons pop up repeatedly.
Sure. So, we sit down, and this was what I did when I was a practice administrator. And then this is really the consulting advice that we give to our practices today. I call it coding roundtable. So, every Monday we would hold a coding roundtable and we would pull the denials either from the prior week or prior month. And if we did start to see a pattern, either by diagnosis or by payer, a couple of things. we would call that care team in. So maybe it's that particular cardiothoracic surgeon, or maybe it's that particular interventional cardiologist that we're seeing, some of the same denials on. We've seen that be very payer specific, that United Healthcare will only pay if you've done the proper care in this order, or maybe Blue Cross will not cover that particular procedure unless you've done this diagnostic first. And so at the end of the day, it's about education. It's tough, right? Because the doctor, the nurse to care team, and the billing team all have to be on the same page. And physicians are very, very busy during the day. So, the idea of pulling him or her aside and saying, hey, we're seeing this pattern of denials. We need to work through this particular piece on documentation. One thing we've seen to stop, the same denial over and over again is also reaching out to the medical director of that payer plan. California has a lot of stringent IPAs. The East Coast has a lot of very tight HMO plans that are utilization plans. So again, building a reference sheet, building a template for each type of procedure and each type of diagnostic that's then payer based. Well, geez, Bill, you're getting into a lot there. That's quite a grid to have it by payer, by diagnostic, by procedure. It is. And that's why we highly recommend attempting to automate what you can, and potentially working with a vendor like Infinix that has what we call IPA, or our Infinix prior authorization solution. We've got a coding accelerator tool. We use various platforms of our own in which we run denial reports for the practice, and we're able to update them weekly on what we see and really be able to nip it in the bud when we see a pattern.
So, Bo, jumping off of this, can you share any success stories or examples of practices that you've seen improve their denial rates and how they did that?
Sure. We have a couple of legacy clients that have been with us as far back as 2017, 2016. And what we see quite frequently is as those cardiology practices either grow or collaborate or become under ownership from another entity, hospital, private equity, whatever that means, they're add either new doctors or bring on doctors to their tax ID. So now you've kind of commingled, or you've started a new physician. And so what we'll see real regularly there is, kind of an early trend of denials. And some of that may be is, well, in my practice, we did it like this, or when I was a resident or a fellow, I was told to do it like this. So, at the end of the day, it really kind of gets back to education and having those templates set up so everybody is kind of in symphony on how they are, really pushing through their diagnostics, their procedures, and then how the billing and coding team is really lining up. And so, for instance, we had a practice recently start 3 new physicians all at the same time. That was tough. We saw an early kind of trend there of denials. They were all associated in this case with seeing more complex patients in the office. So the 99213s, 214s, 215s, and those were, newer, younger physicians, not that far away out from being from training, hadn't seen a ton of patients in the office yet. And so what did we do with those folks? We gave them examples of really all of the components one would need to get a complex 99215 visit paid for. And so once we were able to kind of shed some light on, why they were seeing some regular denials, the providers made sure, again, whether nurse practitioner or doctor, to include all of those components in that complex visit. But that would be one example that we see pretty frequently. If you either have new providers or providers that are new to your group, making sure that you put them through kind of that billing orientation on how you guys do things with your particular EMR, all the way up to, how you close your note after your note's closed. Does it have all the components in it? If you do have a physician order out there for a diagnostic, did you write everything in there necessary or dictate everything necessary for the order? Because that, at the end of the day, is what's going to drive the coding. And that, at the end of the day, is what we go get the authorization on. All of those components have to be in a synchronous order at the end of the day to get the claim paid first time.
Yeah, it's a complicated dance to get right,
It is.
so many
It
different.
is.
So, Bo, looking ahead, how do you see cardiology practices evolving in their approach to claim denials? And what role do you think technology will play in that evolution as we go forward here?
I do think here, whether it's the next 2 months or next 2 years, some level of AI and some level of technology and and really some level of claim scrubber, has to be inserted into your practice if it's not today. And why is that? And is it worth the investment, right? Kind of those two big questions that we get from doctors and practices quite a bit. Listen, at the end of the day, based on all the steps that we've talked about that have to be in place today to get clean claims out the door and avoid denials, AI and using tech-based solutions is such a better, if you will, fact checker and such a better matching platform to ensure you have everything to line up with a clean claim. There's plenty of EMRs out there that have great claim scrubbers in them and will review everything before it goes out the door. And then again, having a platform that like Infinix offers on prior authorization, doing your insurance verification and eligibility. Again, patient access is so critical. If you don't have all of those pieces, correct up front, you're going to pay the price with a denial or a rejection from the clearinghouse in the back. And, again, really what we want to do with practices is help them analyze what they're doing to use their people. And at the end of the day, we want to help practices get their people more patient-centric focused, more patient-centered. So they're really focusing on the patient's journey and not, spending 8 hours a day fighting for denials, right? And so, using automation and using some platforms that really companies like Infinix offer for what is a very strong value proposition in the world of return on investment, just is a real no-brainer at the end of the day, because you can then repurpose and reallocate your staff to be able to pay more attention to the patient journey.
Yeah. I think you're highlighting a trend that we're really seeing pretty consistently here, Bo. I think sometimes it comes across as maybe automation is replacing people's story. And I think the reality that we've seen is that most companies are wanting to automate these more repetitive manual tasks so that they can really allow their staff to focus on providing an excellent, customer and patient experience. Yeah. And that actually can make those jobs better, by, making them less stressful, less focused on repetitive tasks and more focused on providing a high value patient experience. So we are all out of time for today, folks. Thank you so much for joining us. Thank you so much, Bo, for your excellent information here today. How can people find you if they'd like to reach out for more information?
Sure. It's real easy. bo@infinix.com. Really appreciate the platform today and looking forward to any follow-up anybody may have. Thanks again.
Okay. Take care, everyone. Bye.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.